levels up. So I'd like to appreciate our partners, Strathmore University Business School, Kenya Healthcare Federation, Open Faces, UNSDCD Partnership Platform, Ministry of Health, our lead sponsors, Medihill Group of Hospitals, Wasi Health, Farm Access Foundations, HealthX Africa, our standard sponsors, Varian, Unicaf, Qatar, Imperial Managed, Karen Hospital, Gertrude Children's Hospital, the Aga Khan University Hospital, Penda Health, ICA Lions, Zalco, Life Care Hospitals, and all those people who are exhibiting in this particular session. So we'll go straight ahead. The online platform is still working. You can still dial in following the discussions that we had yesterday and today. That's at https://healthexpo.flow.bz. So at this point, I'd like to take us through the next bit of investments in health. Our session 2, which will be moderated by Dr. Elizabeth Gitau from Open Fences, who's already on stage. I'd like to also call upon Dr. Mude, CEO Savannah Informatics, to come on stage, followed by Dr. Egina Makwabe, Chief Medical Director, Africa Health. I also like to call upon Dr. Emmanuel Togun on stage. I also like to call upon Ms. Irene Kayoni from Open Fences. And finally, I'd also like to call Dr. Noel Orata from Pathologist Network as well. And also Dr. Ryan Nyotu, Health Innovations Consultant and Researcher from Kiambu County. So I think we finished with a monthly panel, and now we'll finish off with a more balanced session. So over to you, Dr. Elizabeth.
Thank you very much, Mandela, for the kind introduction, and thank you to our panelists for making time to actually come for this session. Indeed, quite exciting after the morning sessions, having to discuss various health investments, and we had various PE firms here, we had various health economists, we had various eminent people within the health sector discussing the issue of health investments. So this afternoon, our session will be on developing bankable documents to bridge the gap between investors and entrepreneurs in the environment. So essentially, health has been treated in the past as a social good and responsibility of government, but that is changing. All right, thank you. So, but things are changing. We're having a lot more private investors coming into the health sector. We're having a lot of private investment coming in, and there's declining official development assistance from the various funders who are here in terms of the funding mechanism is changing from less assistance to more investments. And here we want to discuss the missing middle, what people describe as the valley of death. Yeah, it has been described as the valley of death because that is where many innovators' ideas go to die because there's no link between them and the investors themselves. So maybe I will begin with Dr. Mude, and I will be asking you to introduce yourself even as you answer the question. Dr. Mude, I know you come from the ICT, and I think this question is a bit unfair. Are there bankable projects in healthcare? And why do we see more prominence in ICT in terms of innovations that get funded rather than the health sector?
Thank you. Yes, the ideas tend to be high value ideas, but one of the biggest challenges that we face the innovators, the startups, the ones that have scaled up and mature companies, is that you find in our sector, you are also competing with two other types of institutions. You are also competing with development partners who are also doing their own technologies. You're also competing with the government itself, and that goes also to how healthcare is financed in Kenya. So if you find that there's a huge portion that is offered by the government, then you find that in that particular sector, private sector technology or health informatics companies won't be playing there. If you find that there is a section of diseases that are taken care of by Again, development partners, again, that's the whole section that is usually closed off from you. So even if you are to get like the whole of the private sector in Kenya, it's still not enough because there are two other chunks that you don't participate in by default. And that's one of the things that limits the growth of and the scaling up of some of the technology firms in healthcare, including ourselves. And I would even say that even when you go to, when you think about NHIF, and sometimes you are not able to participate there, that's a whole now, we could say, pool of transactions that are not available to you, no matter how good your technology is. So yes, there are good technologies, there are high value technologies, but until such a point whereby we can be able to consolidate or have a way to reduce our fragmented pools of either health financing or even providers, it's still a challenge. Thank you.
Okay, thank you, Mule. You did not introduce yourself.
Oh yeah, my name is Mode. I am the CEO at Savannah Informatics and a co-founder there. It has been 10 years of working in the health informatics side. It's very exciting when you think about Kenya and the things that we are able to do from health informatics aspect. And I think the other thing why I love doing what I do is that you still get to do a lot of interactions with the health sector, although not from the technology side. We work for the private health sectors, for the insurance, the hospitals, and also we work in that global health side with donors and also with government. Thank you.
Thank you, Dr. Mude. For the rest of the panelists who've just joined us, don't worry, we'll give you a chance to introduce yourself as we pose questions to you. Welcome. Moving on, just next to Dr. Ryan Nyotu. Dr. Ryan Nyotu is a health innovation consultant and a researcher from Kiambu County, and this also serves in the public sector space. So how far are counties in terms of developing the bankable documents? And what would your county put on the table currently? We've had a bit of work with you as Open Fences to discuss investment opportunities. What are these bankable products you think the county can put so that an investor listening can actually fund?
Thank you very much. Thank you for the introduction. What I can say about counties is, yes, counties are we've come really far in terms of developing bankable documents. We've come really far, but there's still a lot of work that needs to happen. A lot of this work is actually the soft kind of work. It's mentality shifts and different shifts. And for example, I can attest, like in Kiambu County, we've managed to pass the facility improvement funds accounts. So this is previously when revenues would be received by counties, by revenue generated by hospitals. All this revenue would go into the county development fund, and then a bit of it would come back into healthcare. So this is one of those conundrums which we find in public health sector, where we say the health sector is just asking and asking and asking for money, yet the revenue we generate always leaks and goes to fund other projects. So for Kiambu County, we've come to a point where now all the money that we're generating is coming back into the facilities. This has changed the conversation drastically. We were in a meeting this week where the top leadership, and this is where everything starts with the top leadership of the county, where the top leadership of the county was telling all the facility in charges, all the hospital administrators, all the nursing in charges, they were telling them, we want you to capture your problems as business cases, because now you have money. Capture them as a business case, say it as a problem, and then we will fund you. You have your own money. So if, for example, you want to add a new service, you want to start a new clinic, you want to start a new facility, send it to us as a fundable case. So even internally, the county we're already funding ourselves, because 80% is going back to the facilities and 20% is being pushed into a development fund, which we are investing back. This means when it comes to adopting ICTs, facilities can buy. So the journey has started internally. But now when it comes to what products and what projects can we do with private practice, they're also very present. During COVID, we had a huge challenge in procuring oxygen supplies. The end of it ended up being in a form of a PPC, where we were able to enter an agreement with the company, where they will be with a company. I won't mention the company here because I haven't asked for clearance from them to talk about it clearly. But we were able to get the oxygen from the company. We were able to give them a wide use. Kiambu County is a very big county. We have a population of 2.4 million people and around almost 120 public health facilities running with very many healthcare workers. So the models are there. The counties provide an avenue to scale. So the work that's left is about creating the structures that allow for this engagement to be really, really fine-tuned. Thanks.
Thank you, Ryan. Just as an addition, how you've mentioned regarding business cases. How can we, sometimes the issue of bankability of the healthcare projects becomes quite difficult to actually document. You know the outcome you're looking for, but it comes very hard to document this return on investment. So possibly you can maybe give your thoughts in terms of how can we create a compelling business case for either a private capital firm or even national government to actually fund some of our projects.
One of the models that I've really come to like, and I'll thank Prof. Frank for this one, is the outcome-based funding models. These ones are very ripe and they are very easy. They're almost turnkey to insert into the public health system. This is where, for example, what we're going to be doing is we're going to be asking facilities who are within a particular sub-county, and by facilities I mean all care levels, I'm also including the community health units. We're going to ask them to capture their entire problem as a business case, and then we have the outcome we want, the exact outcome we want. So that we're not talking to donors, we're not talking to external funders. We can tell them that if you come in with this amount of funding and you do this amount of, and you give us this amount of money, this is the outcome we're able to give you. But the first part, as I said, has to be the mentality shift. Because one of the main challenges we're seeing is at the top of the county leadership, we may have this mentality shift. In MOH, we may have this mentality shift. In this panel and these conversations, yeah, the mentality shift might be there. But when it comes down to the level of the clinicians and the people who are working in the facilities, this message is not passing through. We're still seeing service delivery models in our silos. So until that changes, until we get there, it's going to be a challenge. So I guess if we start with the models which are already turnkey at the moment, like the outcome-based models, and we do them for some time, what you'll find particular healthcare workers already starting to see how to do this. A simple example of this was something that happened with our ophthalmologists. They started to do this type of work where they were actually really focused on outcome-based. And at the end of it, what happened is they took up the project, developed a case, and it ended up being funded by external organizations to a tune of a really big amount that I won't go into. Thank you.
Thank you. Now we cross over to Tanzania, where Dr. Egina Makwabe, who's the Chief Medical Director of Africa Healthcare Network, and also is the Chair of the Association of Private Health Facilities in Tanzania. So investors tend to invest in what they know, and while they may be interested in what we are doing and in the space, sometimes the threshold of what they know within the health sector or the healthcare knowledge is not comfortable for them to invest within the healthcare space. So what kind of process can we institute to support development of these bankable projects for people to understand the health sector, for even investors to understand the health sector, so that they can be able to invest within the health sector in East Africa?
All right, thank you very much. That's a very good question. And thank you for the very good introduction. So these bankable projects, especially when it comes to private sector, it's not an easy thing. What the banks looks at is a cash flow, especially if we are private. They look at the cash flow. You might have your own project, very good write-up, your own vision, that this is what I want my project to be. But the bank will not look at that. The bank will look at the cash flow that you have. What are you generating? How are you going to repay when we give you a loan or when we fund you? How are you going to repay that one? So that becomes very, very difficult. So if you want to write a bankable project that will get funding from the bank, number one, then you have to make sure that you know what exactly the bank wants from you. You have to do feasibility study all the banks, go through their requirements, and then write your project depending on what they require you to provide. So that is one. Second is when you are writing a bankable project, not to the bank but to other financiers, then you need to know what exactly you want. That means you have to do a feasibility study, the impact that's going to to provide in your community? And then those organizations, what do they want? So at the end of the day, you have to get a meeting point, and then they'll be able to provide funds. But in private sector, it becomes difficult that no one will give you funds if you don't have collateral. And having collaterals in the private sector for beginners or startups becomes even much more difficult. So that's why you might find some healthcare professionals, it takes time for them to develop a significant project as they start small, saving, getting small loans, which takes them time to reach a point where they'll be able to get big funding. So you have to find and get a meeting point where you'll be able to secure a big fund, and according to what is required by the financial. Yeah.
Indeed, thank you, Dr. Makwabende. I like what you have described in terms of a business case, feasibility studies, cash flows. I think this is one of the areas, especially in the public sector. We usually, when you're going to a funder, we do not show them in terms of how we are going to make money based on this project. So indeed, this is quite good insights in terms of ensuring that even as we're going to fund us, we are going with actual thoughts or visions as to how our cash flow is going to look at, even as we implement various projects. Just to jump over to Southern Sudan, Dr. Tungun, who is the Private Health Sector Association lead there. So maybe to paint a picture from South Sudan, even before I ask you about the challenges, do you have any public-private collaborations there in South Africa, in South Sudan? And are there any projects that have been funded by private capital that you can mention? And what are some of these challenges within your environment that these entrepreneurs usually face, and in terms of developing bankable documents to support them?
Thank you very much. My name is Emmanuel Tungun. I am, I run a pharmaceutical company in South Sudan, so we do both retail and we import. And number two, we also started off on doing turnkey projects, refurbishing more or less operating theaters and other small projects around for various people. Also, the other side is I work with the private health sector. And in terms of bankable documents, like you said, cash flow statements, profit and loss, the balance sheet, you have to have your books in order. You really have to have your books in order. And unless you have your books in order over a period of time, the banks will not really look into you. And even if you have collateral, they will give you X amount, which may not be the amount that you want to start with. So for example, let's say you need, you're putting your car as collateral and your car is worth, say 1.5 million Kenya shillings, and you needed 1.5 or needed 1 million Kenya shillings to do the job. The banks will come and say, no, we'll give you 750, which is still below what you wanted, but beggars cannot be choosers, so you have to find a way to fill the gap through other options. The other options is, of course, to go to other equity partners. And in most cases, it's very hard to convince people, especially the rich people who've got the money, to actually invest in healthcare. Because to them, they don't see the returns as something that materializes quickly. Remember, most people want money yesterday. So I invest today, in 2 days I'm asking, hey, where's my percentage? And of course, with the health sector business, of course, it's actually a gradual, slow business. You have to build it up and everything else. So with the banking sector, we had issues in South Sudan before, whereby people got loans and a lot of defaults happened because of the war and everything else. So property got destroyed. So banks are very risk-averse. They refuse to give loans. And if they're giving you a loan, they will need your collateral, maybe property, your grandfather's marriage certificate, God knows what else, and they'll be asking for ridiculous things that you'll never want, and still charge you about 27, 28% interest. And within giving you a very, very short time to make the payment. So it's almost impossible to get the guarantees and to get everything out in time, unless you're actually going in small blocks and you have to work twice as hard to get your money back so that you can repay them. With getting people to come in with equity, of late, in the last, I would say, 6 years, there's been a bit of a change, and there's a lot of big people with deep pockets slowly coming in to fund some small health projects. And we've had an amalgamation of various doctors and specialists who would come together to form their own center, and they'll bring in a big partner to come in and fund it. So that's actually working quite well. On the other side as well, we're also working with those facilities to try to give them, okay, we go not because of their bankable documents, but also because of their reputation, because we know what they're doing. So in the case of my company, we'll be willing to assist them and to more or less kind of fund them on credit basis to a limited extent, knowing that we'll get our returns over a much longer period because we know how long it will take. So for example, you're setting up a small ambulatory clinic and you need ABCD. Okay, fantastic. I will come and I will set up part of your OR. We'll agree on the payment terms. So you'll be paying me X amount of time over a couple of years or a year and a half or so. But at the same time, I know very well you'll be using my consumables. For you to do your operations, you'll be coming back to me to purchase switches, to purchase other gauze and various other consumables. So it's more or less of a win-win situation. And this is kind of what we're actually doing with some of the smaller companies that are working over there as well. And hopefully as we're going forward, things will improve. Thank you.
So thank you so much, Dr. Tongun. Indeed, some of the comments that you've made, many of the investors and also entrepreneurs here agreeing with you. And even as we jump into some of the stories in public-private collaborations, I want to ask Dr. Muthe, he's built this Savannah Informatics from a startup to now a business, to a viable business model. So how did you escape the valley of death?
First, I think the valley of death is real, and it's not only once, I think 3 times. So I've been there 3 times, and so I don't know whether it's something you can escape. Second thing is that when you go even to a fund, a VC, a private equity, or even a bank, the first thing, even when they ask for your balance sheet and the like for a couple of years, they say you don't have enough assets that are physical, because if let's say you're in technology, your assets will be software, and most of the time we were talking about 100 MBs. So your bankers, your VCs, they'll ask you, in case you default, in case you run away, how do I sell these 100 MBs? You know, that's all your assets. And those 100 MBs, you know, like, just you can imagine, those 100 MBs could be worth a couple of millions, but for them, they're wondering, how do I auction this? So there's a love for the immovable things, the land, the cars, the logbooks, and the like that we tend not to have. So so you need to bridge what's available. What's available to you most of the time will be grants, with also commercial angel investors, with loans. You'll have to bridge what's up. And for me, the first value of death was fixed by USAID in 2014. The second one was fixed by AstraZeneca in 2016. Brad, now Satya, also fixed certain, so because that's what's available, you know, and because for them, they are able to take certain risks. So if we work with you for this 6 months, at worst, there's a small amount for what our whole portfolio is. So there is somebody who is willing to grant you and work with you. And then the other thing that you escape is by backward integrating to universities, because the biggest challenge if you're an innovator is not even the market, whether people will buy your product, it's whether you'll have employees that are able to execute on the products that you want. So unless you have that MOU with the University of Nairobi, JKUAT, Strathmore, and those are the MOUs that we have, whereby they are willing to give you talent, and you're willing to employ that talent and grow with it. So you need to fix the talent, but also you need cheap capital that doesn't come with a lot of requirements, and both parties know that it may go kaboom, you know, it may not work. So you need that. Thank you.
Thank you, Dr. Muthe. I would want to jump over to Dr. Noel so that she can handle the other panelists in terms of just giving the untold stories. And even as that, maybe the panelists can be thinking about how can we create this ecosystem where we support innovators to actually move from ideas to business models that are fundable, even support county and national governments to move from ideas within the country, policies within the country, into bankable documents. So maybe you can be thinking about that even as you listen to some of the stories of innovation.
So welcome to the afternoon session. We decided to combine our panelists. My name is Dr. Noel Orata. I will be taking the second panel today. We decided to flood the stage because healthcare is just a complex mix of everybody at the same time operating in their space, but still within a bigger ecosystem and, within even different sectors. Health workers in the health field, but, those in the health field are not necessarily healthcare workers, and it works. This is one of those unique fields where you don't actually have to be a healthcare worker to be in our space, and it works just fine. So welcome to this session. In my session, I want to keep it light and airy. I think we've done the hard conversations. Kamarogo took us through intense reflection and introspection. We thought about it and we were almost cheering in the corner. We were like, yes, government of Kenya. And I'm sure, Tanzania was thinking about South Sudan, was probably in that space as well in their minds saying, you know what, maybe it's not that complicated. Maybe we need to optimize the limited resources that we have to actually better healthcare systems, and then it will easily then attract funding and get, the right people to the table. So because I want to keep it light and airy, and I am also done thinking about PPCs, we'll pick it up tomorrow because that's the way forward. Kenya, we are no longer classified as low income, we are middle income. So it means we have to quickly think about how we're sorting ourselves out. And I can see Ryan laughing here because I'm sure Kiambu County are feeling the pinch a little bit. So welcome everybody again. And I wanted to go into stories. So I wanted to go into elevator stories, and we're looking at success stories. I think we've talked about what is the problem with all our healthcare system, the challenges we have, and we know them. We sit in them, we stew on them, we think through them, we are strategizing through them, but it's not all grim and doom. There are actually good stories out there. And I can see my panelist here, John Kamara, sitting next to me, and why I'm so excited is his title. His title is Chief Inspiration Officer. So I'd like him to inspire us with, great stories of public-private collaborations that has really had social impact in the community, probably ideas that have come up. I can see you're from a Danian lab. So when I first read labs, because I'm a pathologist, I was like laboratories, but I know it's not that. So maybe you can introduce yourself, tell us about the labs, and a great 5-minute story on a success story that has made a difference in the healthcare space.
Thank you very much. Can you hear me?
Okay,
this is much better. Thank you very much. My name is John Kamara. I'm the founder for Afia Record. So Afia Record is a deep tech, patient-driven healthcare platform focused purely on patients getting access to their health data, mobility of that health data, and use of that health data to provide better healthcare in the very fragmented health ecosystem. So, so that's what we do. That's what we started out of here in Kenya, to build a deep tech company that could compete with the world. Because basically our clients are global clients, not really here in Kenya. I just came from Paris, from Change Now, where we're representing the country with deep tech companies from Johns Hopkins and lots of different places, and we expose our technology to them. And the first thing they asked was, it was built where? And we said it was built by 12 young Kenyan developers here in Nairobi. And we came second in the global UN competition for deep tech health startups. And the reason why I'm saying this is because one of the investors we were talking to asked us a question, are we an electronic healthcare company? And I said, no, we have zero interest in being an EHR company. What are we? So we're the Google of healthcare, we're the Gmail of healthcare. 10 years from now, the whole world will know about what we've done and what we're doing, the journey. And so you asked me a question, but there are other problems to solve in Africa. Why are you taking on these very deep technical problems? Because we can. Those problems don't have to come from Europe. They don't have to be solved by people in Europe. Yes, we can, even if we don't believe it ourselves, but we believe that we can. So when we started Afia Record, pretty much nobody believed what we're doing. Till today, a lot of people still don't believe what we're doing. But then, and we talked to government, we talked to a lot of people about just a unified patient-driven healthcare platform that allows, I asked 2 questions. Do you have access to your bank statement on your phone now? Everybody, just raise your hands. Most people have to their bank statement. Can you just show me your healthcare record right now? Anyone at all? That's all we're solving from a unified global perspective. The world has woken up. Either people like it or not, either they say it will happen or not. Everybody will get access to their healthcare record at some point. And we're positioning ourselves to be the ones that solve the global problem. So we're not solving a Kenyan problem. So our story was, we met Sister Joyce Meyer, who is like Mother Teresa. I met her in California in 2019. And I made her a promise that I would power rural hospitals, which were run by nuns. The nuns don't have a lot of money to pay anything, so they couldn't afford any healthcare software at all. And for us to get paid data to the patients, we need to help digitize. So we ended up building all these tools, and we went to little village hospitals, level 1, level 2, nuns who don't know how to use computers. They don't have electricity a lot of the time. They don't have internet. So we built a platform that had to deal with all those problems. So the nuns, then I called Sister Joyce Meyer. I said, we're going to power 340 mission hospitals in Kenya for free. We're going to make them way more digital than even the bigger hospitals when people go into these places. And even though they're not government, but they acted like government because they provided healthcare to all the people in these villages. And 70-80% of us still live in village in Africa. Most rural, if you leave Nairobi, Mombasa, Kisumu, that's it, really. Most people still live in semi-urban and rural communities. So if you take that into consideration, you realize 80% of data is lost at that particular place. So we started powering these nuns. We helped them to power their little hospitals, and they became digital. They learned how to use the platform. Each of them later, we bought them computers. We got a lot of funders to donate computers to them. Because we spoke to the big hospitals and government, nobody believed what we're doing. So we decided to just work with people who actually needed our help the most. And 2 years later, I'm proud to say we've powered about 50 of their hospitals. We've had over 120,000 of their patients to have access to their healthcare record, and we created mobility. So for hospitals, what we normally do is we create mobility of healthcare record. Once we power one platform, when the patient goes to another one that has Afia record, they don't have to be connected hospitals. They can drag you from the cloud, and they get access to your health record before they treat you. We save 30% of time wasted and 30% of misdiagnosis, and we save more people's lives. So that's what we went to talk about in Paris. Thank you.
Oh, that's amazing. Because none of you has a health record here, but someone in a rural area has continuity of care from the doctor who's seeing them in different facilities, and as such gets better care because then there's no repetition. Yeah. And then the doctor also gets a full picture and a previous history. That is really amazing. I think, with the CSR that the company is also doing, that's absolutely commendable. Like I said, we're keeping it light and airy. I think there's a lot of good things to say to that. Maybe I can go online. So Dr. Lea Mwai is with us online from ID Insight, Western North Africa. And, not yet. Okay. So I think moving on to the 2 beautiful ladies at the end of the row. And I'm looking at Irene. Irene Hayoni is actually a very special lady. We work together at Open Fences as part of the core team under Prof. Wafula, our team lead. And we've done quite a bit of work on bringing private and public sectors to talk to each other, collaborate, look at partnerships, low-hanging fruits, bigger projects. And I know she's been involved in COVID-19 work. And I think the story I wanted you to share, or what you want to share, would be around what innovations have you come across around COVID-19 and the impact it has had in the population.
Thank you so much, Niall, for the lovely introduction. Yeah, so we've been doing some work in counties and also at the national level, and just trying to look into some of the innovations and analysis of just the policies that have been done during the pandemic response. And we've also picked out on some very interesting innovations. They vary. Some are technology-based, some are not. So some of the non-technology-based ones that we encountered is this program that was targeting school-going children because they are among the most vulnerable student population, that is. And what they did is they had classes organized for them during the pandemic under trees. So they started small with like 5 children, then went up to 20 children, up to 40 children. That was done in Lamu County in the rural areas. And we thought that was very innovative because given the difficulties they had with internet connection, the students still got to learn. When it comes to tech stuff, what we found out is there's a lot of need to get all the data that's essential to just be able to prepare for pandemics and all that. And so the Lake Region Economic Block, the one that has 14 counties, where we have Kisumu and Trans Nzoia also, has this database where they collect information on health facilities, the positivity rate, just surveillance data, and also look at the economic background, the vaccination uptake of the population. And they are able to do statistical modeling and predict where we are going to have a next wave, if there are measures that are supposed to be taken, and also provide policy brief, which we found very innovative. That's we collect data from both public and private facilities, but it's being done with the help of Farm Access and the Lake Region Economic Block here. And then building on that, they've just, they're planning to upscale it. And just for pandemic preparedness, they have EpiDX. Now they're working on a database which can pick out all possible indicators for any pandemic that would pop up. And I think when it comes to pandemic preparedness, that's a real plus for the Lake Region Economic Block. And it's just good to see real-time data streaming and how consumption of it has been able to inform a lot of policies around that. But mostly we've been finding information to do with use of Wi-Fi. SEMIs went virtual and all that. And so it's really nice to see how a pandemic brought a lot of good and how innovative Kenyans became to just respond and be able to align and just get normalcy in times of a pandemic. Thank you.
I think it's amazing how Kenya takes up technology, especially when we really need it. We take it up really quickly. Besides M-Pesa, all the other health tech we took up. You know, for me in the medical space as a pathologist, you know, COVID was a global experiment. We were changing protocols daily. We were learning about the new tests we have to do, PCR on COVID, and from a national level and a block level. So that's, you know, several counties, and at county level, it was amazing to see the data that was being churned out and the coordination that came together. But more than anything, the numbers we were crunching, you know? And so it was informed decision making, which will even help us with forward planning. So I think that's a great story. I can't wait for it to become big. You know, now we were talking about epidemiologists, you know. Generally, I talk about the healthcare sector, it starts with the doctor, the nurse, in Kenya, clinical officer, and it sort of grinds there with M-Pesa and, you know, these other platforms. But now, you know, when you say MTBA, when you say, you know, whatever platform, everyone is really conscious and aware. So that's a great story. So I see Sharon sitting there. And Sharon, you're the CEO of Lish Living Nutrition Clinics. And I'm sure there's a story you have for us around the work you're doing and the impact it has had on the community and how it informs decisions that are being made, you know, within the community and at county level. Maybe you can give us a little tip, maybe introduce yourself as well.
Thank you very much. My name is Sharon Alago. I'm the founder of Lish Living Nutrition Clinics. Probably just to get this clear, I'm not a nutritionist. And to get this clear again, I'm not a software developer. I am just someone who actually saw the need in the healthcare industry. Now, most of us, when we speak about nutrition, we think about general nutrition. And this is just nutrition. Oh, yes, you should eat healthy. You should eat this, don't eat that. But there's nutrition for people who need it. There's medical nutrition therapy, clinical nutrition. Now, what we work on is nutrition for people who actually need it to get better, need it to either slow down the progression of the disease, if not that, to treat it. So what we are is that we are a team of medical microbiologists. We have a team of medical microbiologists and nutritionists, and we created, I think, a software, a tool, I would say. We started by creating a tool that we thought would be used in the hospitals. And this tool is amazing because all you have to do is key in your anthropometric or biochemical measurements, select the disease, and then click on generate nutrition assessment. If not that, sorry, not nutrition assessment, but nutrition report. But if not that, have a whole diet assessment. Basically, we can be able to tell you based on what you're eating, what you've eaten for lunch, is that the right food you should be consuming if you have diabetes, if you have chronic kidney disease, if you have gout. We've got 54 health conditions right now. So when we created, when we built the software, we thought that it would be obvious that nutritionists would be in hospitals. But you would be surprised to find out that 60% of hospitals do not have nutritionists. So we keep talking about the healthcare industry. We keep talking about, okay, what can we do to improve, to reduce the incidence of diabetes, hypertension, chronic kidney disease? How can we improve the incidence if we do not have nutritionists in the hospitals? And I think this is actually a fundamental question that we should all be speaking about. We have 650 nutritionists, 650 nutritionists hired within the government system, government hospitals. When it comes to private healthcare, I promise you'll go to 10 hospitals and then on the 11th probably you'll find a nutritionist. So when we came in, and I think this is also a conversation we should be having about who carries the risk, because as startups, we came in with a tool thinking that it will be used in hospitals, and now we have a network of 105 nutritionists because we have to get into the hospital with the nutritionist. So we train the nutritionists, we hire them and work with the hospitals on a revenue share basis, because also because hospitals have not been having nutritionists in their hospitals, it also means that they still do not have the service offerings. And I think just being able to have the service offerings in there, where they know, okay, you have 3 different products. You have a nutrition consultation. You have a diet assessment that takes 3 days, where a patient can send you photographs of the foods they eat every day. And at the end of the 3 days, they will know, okay, based on my chronic kidney disease, actually, I shouldn't have had so much potassium, because it exhausts the kidney to this level. But they can also see, this is how much more that I had. Because if we can know the gap between what we are doing and what we are supposed to be doing, then we learn. And that is the gap that we are actually bridging in the hospitals. So far, we are working with private hospitals, 18 of them. Apart from that, we've worked with the county government, I should call it the right name, Nairobi Metropolitan Services, where we've carried out outreaches. Beyond that, we do have a partnership with the University of Nairobi, because it's also a matter of working together to see how do we lobby for more nutritionists in the hospitals. Maybe just to speak a bit about the impact of what we've done. We ran a pilot study when we started with 308 diabetes patients. Out of the 308 diabetes patients, 54% reduced their medication. And the monthly savings ranged between 530 shillings per month to 5,700 per month, simply by eating the right foods, nothing else. Eating the right foods, exercising, and just getting someone to prompt them. Have you exercised today? Have you checked your sugar levels? Because that aspect of health coaching is what is going to transform what we are doing. But it takes a concerted effort, because we have to think, as people in the healthcare industry, We have to think about integrated patient units so that we do not look at a patient as someone who just goes to the doctor and then goes to the pharmacist, but we look at a patient as the patient. How do we make sure that this person, when they get into the hospital, by the time they leave, they're on a different level, they are actually healing. We are slowing the progression of their disease. Or for those who we know that, okay, there's a lot of pain, pain management required.
Yes, let me reduce the volume.
The nutrients have an effect.
Okay, so
in
let
terms
me
of
reduce the volume and I can see two screens.
So
See
this is what we do. We are young, we are 4 years old, and if there is any hospital here, I'm happy to set up a nutrition clinic in the hospital. Thank you. Thank you so much.
Hello?
Thank you so much.
Hello?
That is so
I can't hear you.
because I think, the world is moving to wellness. Wellness tends to be affiliated
Okay, but
with the
okay, and can you hear me?
society. And
I can hear you.
on the ground. The other day we were discussing for food and we were talking about a potential obesity endemic.
At the bottom, wait.
And oil.
Join panel. There is no
situation that may go down. Oil is quite high, but
wait.
But these are things we can tap into now using a platform and actually have a healthy population. So someone was saying, healthcare is not a money-making sector, and it's the truth, but it gets the most funding, but we don't make profits from it, at least from a public perspective. I always say that the benefit of healthcare and the investment in it is that then you have a young, healthy population who then bring the economy and the GDP up as a whole. So there's still benefits to getting it done. So thank you so much for your project. I think we in the urban sector suffer because many of our startups start in the rural areas. And, some of us, you're just too busy to take it up, yet it will make such a difference. I see myself using your platform to make a difference, and I think I'd have a great story. So I think it's something we can take up as Open Fences. These are the partnerships we're looking at. How do we impact the community? Because social impact is big for us. We're looking at, all genders, men and women, mental health, and the whole spectrum of healthcare, and how we can make a difference. So thank you so much for that. To Dr. Ryan again. So Dr. Ryan is our innovations consultant, and I know he's doing a lot of work as a doctor in the AI space, artificial intelligence space. And, I want you to tell us a little bit about the work you've done in Kiambu and the success stories and how you've been able to use data to, make decisions at the county health management team level, at the CEC level, and what impact it has had on the community and what changes have been driven by these innovations that you're doing.
Just start by saying to everyone
yeah, I've done.
We have quite a bit of data, and we have quite a robust research team that looks at this data. In conclusion, one of the things, for example, that we found was a lot of the issues we're talking about here are based on sociological inefficiencies. This is part of where the machine and the data analytics systems will come to kind of augment. For a very long time, when we've looked at sociology as a field, we've always looked at it from a qualitative research type of lens. But today, we're in the era of computational sociology, where we're able to apply quantitative metrics to social principles. And what this has done for sometimes is it's able to enable us to bring value out of systems we understand. For example, our previous ambulance system used to be facility based. So the whole county, if you need an ambulance, you would first of all have to start past the conversation for the need to a decentralized person, maybe a med group or a hospital administrator. Then this information would have now be conveyed to the driver who's maybe a facility central, and then it would all take a long time. Just looking at it, where we write the and so that the department planning and administration. So I will come and look at it, and they found just specializing, just looking at the data and deciding just by centralizing the ambulances. We entered a partnership with a private company who were able to give us just 6 additional ambulances. These 6 additional ambulances are now being coordinated through a centralized data center, where the calls come in, and immediately they are dispatched. So we don't have average time born unless to get to you. Once the message gets to them, is 4 minutes. This changes everything. This changes how we're dealing with emergencies, changes how ready we are, and also changes the preparedness by the facility folk. This all came from this situation. But the conversation doesn't end there. When you utilize data, what you do is you open doors, you open opportunities for further engagement. For example, one of the success stories we've had by interacting with Open Fences is Open Fences was able to help and come and get Kiambu and have a seat together with the private sector, teams. Now in the private sector, they are the heart for the private sector. In the private sector, we also we have an engine which is a computational sociology based M-Health tool, which allows us to come into any network, map it out, extract the information we need, and operationalize it for function. So one of the deployments are in disease surveillance, and so we have a tool for disease surveillance for trauma, where we're looking at how can we then reduce the time if from call center to the ambulance coming is 4 minutes. The delay then is in identifying there's been an ambulance, there's been an accident here, there's been a problem there. So, for example, the challenge we've been having, how our tool used to work, and it was an interesting conversation because here we were private industry player like technology. We had our private partners in healthcare delivery in Kiambu who are like 500 private hospitals working within Kiambu County. And then we had a presentation from the public side. So as we were discussing and telling them about how using data from the public health system has really helped us kind of move forward. One of the things that came back to us, and it came back nicely, was how big an opportunity this presents to us to come and deal with the health seeking behavior of trauma or other types of emergencies. Because in our system works is our system maps out accident-prone regions. We identify healthcare workers who are there, pharmacies and small organizations, and we give them capacity for basic life support. And even at times we give advanced trainings. We give them HLS trainings. So what this does is, as soon as there's an accident, there's someone who comes there. Someone's able to come there in a very rapid time, and we're not going to get them from far. We utilize them from there, and then from there we're able to alert the system around us to base this here. This allows us to launch other services on top, able to work with ambulance dispatching services and like that. So we're having this conversation, and we hear ambulance to people from the county. One of the interesting things is the private partners in the county. So imagine if we have ambulances that each idle for a holiday because we have no referral. We are paying driver a monthly salary. Why can't we come any part of the system? Why can't we all together and work to try and reduce it? All this comes from county administration. Looking at the efficiency of their system, we have this mega resource. How efficient are we use it? We apply analytics to develop a metric to allow for it to go further. And now the beauty about it is the engine, the computational sociology engine allows effortlessly for AIs to come and plug in, and for more advanced technologies to come and plug in. So now what we have here is a whole value chain where it can come from the county facility, from the ambulance, all the way from the person who's at the ambulance, and now this can go into advanced analytics. So the future is bright, evolution is working, and we're going to get there. Thanks.
Thank you so much, Brian. Kiambu is an amazing county because the number of CT scans in Kiambu County alone is more than Malawi and Zimbabwe combined. Yes. And they have a very robust private sector. As Open Fences together, we were able to organize them. And once they started having the conversation, it was amazing to see Kiambu County leadership then talk about Kiambu ecosystem. And now they started discussing, our resource is public and private. It's not we are government, so we are stuck on authorizing, supervising, and regulating. But everything in anything healthcare in Kiambu County is ours. And so they really took up that conversation, and they're really running with it. Kiambu's, response time is amazing. I remember when we were having the conversation, they were saying, if this CT scan is in use, because of AI, we'll know. So the ambulance will pass and go to the empty CT scan where the patient will then get immediate imaging and timely decision making, and then timely management. So it was an absolute pleasure as Open Fences and the team working with the different counties. Kiambu is represented here. Dr. Masibo was here earlier from Tanzania County, and we discovered that different people actually know the challenges. It does not have to be prescribed for you. We know our challenges, and I think if we're put in a room and told to think about it, we'll develop the solutions. And I was so happy when I had Dr. Kumar yesterday, Dr. Prata saying, are these solutions going to come from England and France? And it was rather obvious. We just sat down, right? And we will generate our own solutions because we know exactly how to do it. From the funders, and maybe we just need to package it right. This is where even Open Fences does that. We're able to help you develop investment cases that are bankable. So thank you so much for the stories. We're keeping it light and airy. Healthcare is not doom and gloom. And I think whatever stage we're at for all countries that are here at the East Africa Expo, it's just a matter of going to the next level. Does it mean, and all the things Marugo said this morning that was so insightful. So finally, we have Dr. Lea Mwai online. Welcome, Daktari. I hope you can hear me.
Yes, I can hear you. Can you hear me?
Close with you. And you're going to introduce yourself. But for you in particular, I have a specific question. And just based on your experience, what, in your opinion, works best for public-private collaborations in any aspect, finance, infrastructure. Sorry, I think I'm echoing myself.
Hi, Noel. I had your question. There's some feedback there, but I think the request is to introduce myself and say what works best for public-private partnerships in any aspect. Can I confirm that that's what the question? Hello? I'm just checking that you can hear me.
Yes.
Great. Okay. Thank you, everyone. So my name is Lea Mwai, and I'm a director at ID Insight. And I'm a health professional, as well as a researcher and an innovation expert, as well as enthusiast. So really feeling at home in this, following some discussions and really feeling at home. And it's really nice to see some familiar faces. And I'm really grateful that there's accommodation with technology to be able to participate online. So I'll tell you a little bit about what we do at ID Insight before I can say what I think is the question you asked about public-private partnership. So at ID Insight, we're a data analytics research organization that is client-facing, client-driven. And I want to underline that because I know that most people will know in healthcare, in research, that usually research has a background in this field because a lot of research is really academic, not really focused on supporting any practice or decision making, and there's a lot of challenges with that. So ID Insight is looking to fill that space. So we use data and evidence to really support decision makers, whether they in the government, private sector, to really make decisions that have an impact that drive their social impact, maximize their social impact, and by that meaning maximizing the impact on the reach of their investments. And when we talk about social impact, it's to really make sure that the programs or investments that are made are really reaching and going over and beyond to really benefit people who are sometimes even excluded. And we use, one of the things that's different from the way ID Insight works in terms of research is we really tailor a wide range of toolkits to really be responsive to the needs of our clients, our decision makers, which means that we don't use the typical timelines for doing research. Sometimes we can innovate, so we are very innovative. We have a data on demand initiative where we try to do rigorous data collection or research within short timelines, trying to use also machine learning, AI, frontier technologies to really help decision makers for specific use cases, really reach decisions quickly. So your other question, Noel, was about how I've seen public-private partnerships work. I'll confirm that that's what you meant, but I would say that one of the things, and I think where we are adding value a lot as ID Insight, is the important thing about really being data and evidence-driven in driving how we monitor or track or design public-private partnerships. So I think this is one of the things that's really helpful. I think a lot of the problems we have with public-private partnerships, a lot is the lack of trust that comes from having massive programs that don't have any impact, or that don't track anything, or that don't have any meaning for decision makers. So I think we're really interested in, or at least some of the reflections about how to really, at the beginning of these partnerships, to make sure that we have, we establish some good monitoring, learning systems, identify some priority metrics, and not have the kind of metrics that are usually, in development, where there are more accountability and very cumbersome, and nobody cares about them, nobody measures them, to really identifying things that will help us know when we're making progress. And then also trying to really be bold and to leverage, move with the market, move with the private sector. A lot of the innovation that is coming in healthcare, as we know, comes from the private sector. And I think the challenge is really to see how to make sure that that can be scaled up by government in ways that really benefit those who need it, which means, again, it's really making sure that we're using the right methods, very rigorous, and looking at what matters on the ground to make sure that we're measuring that impact. And I'd be happy to really talk about some of the ways we're doing that, like some of the ways that private sector is coming in, for example, in healthcare, is around supply chain and delivery models that are using digital systems, drones. But again, it's all these shiny and good investments are really great, but unless we really study them and measure them, we may not be able to understand how to really optimize their use, or how we integrate them into the healthcare system. So at ID Insight, we care not about just the what, but also the why and the how of how we introduce new investments, new technologies or solutions, and to really study them. And through the work we do, we are able to advise our clients on what aspects of their programs or solutions work best and should be strengthened or scaled up, and what are the ones that maybe are not so beneficial and costly, not value for money, and should be removed from or not continued with. And that way we are really able to help our clients make really good decisions about that, and be able to streamline the investments that they are making. And there are a couple of examples we've done, as I say, some of the work around drones, some of the ones work around scaling up, say, health vaccines or health technologies in specific context, and being very clear to really study how the scale-up model for that specific context. So I will stop there, but I'd be happy to provide more insights and if needed.
Go. What is the most fascinating? What's the most fascinating, impactful story that has had a lot of impact in the community from the work you've been doing?
Okay, great. Is that to me, Noel? Just to confirm. Can you hear me? You're on mute. I can't hear you, but I can see you nodding. So go ahead and answer. Great. Okay. Yeah. So one of the most impactful stories I would say is how I was in the other talks before, and I had the discussions about how health is being in terms of the discussions that are being done in development with private sector. Health is usually there's a lot of technology but less health. I would say one of the ones that come to mind for me is how health through this frontier on new technologies. People are leveraging those, and we are supporting some of our partners to use those to really maximize, I would say, impact at scale. So I would say one of the ones that really comes to mind immediately is one project that we are supporting the Department of Health in South Africa. It's called Mom Connect, and we are currently working also on a Young African Life component. But basically, it's leveraging, what we have, the technology that we think sometimes is not very well integrated in healthcare, but really cell phones, social media, to really drive and measure how we can achieve good outcomes for women and youth, maternal and child health outcomes, given that it's already a ubiquitous technology. And really, we come in as an idea insight to really make sure we are understanding that impact and what aspects of the technology work, how it's perceived, and the fact that we work then with, and this technology, as I said, cell phone based, so a lot of private sector, social media with groups such as WhatsApp and Facebook, but working together with the National Department of Health in South Africa is a really good model, because we're able then to work with that policymaker and decision maker that can really scale this to millions of women and youth in a way that would help us to reach people we would never reach if we didn't leverage the technology. So I would say I've seen the real opportunity of leveraging technology when done well in a way that can really help to reach groups that and pass messages and communicate to communities in a way that has not been done before.
Insight into public-private collaborations and the work you're doing. I think all around Africa, in the reproductive maternal health care space, neonatal child. So we call it RAMCA, the short form. I think everybody has a different acronym for that, but more than anything, as long as the population becomes healthy, then you have a productive society. So maybe just to close, I shall pass it on back to Elizabeth, and then I will finish.
All right,
So
thank
I'll
you.
allow to-
Maybe John, maybe you want to come back up? All right. So maybe to close to our panelists, there's a question I posed to the panelists to think about, and maybe allow our friends from the African community with us to have a word debate before we take it to the other members of the team here. So, what do you think the ecosystem? What do you think can be better coordinated within the ecosystem to translate the various ideas into investments? So, what is it that ourselves as private sector can do to ensure that we are ready to be funded? And secondly, what do you think in terms of growing the ecosystem, government, development partners, what can they do to stimulate this sector to ensure that every innovator that comes actually is able to be incubated? And John there would want to have something to say about incubation. Can be incubated. Their idea can be incubated or even scaled to a viable business model. Dr. Emmanuel can start.
Okay. If I look at a couple of things and how things are going in Kenya, for example, some banks are slowly shifting from, I would say, the traditional way of doing things to getting involved in industries that don't involve banking or finance, for example. And it's paradigm shift in how they're doing business. And one of them, which I like following a lot, is Equity Bank, and how they've gone from being a bank to financial services. Now they're offering equity help. They're now into telecom as well, with their mobile systems and their payment systems all integrated into one. So they're trying to give this holistic thing across. And I talked to a friend who actually works in one of the branches, and they're actually now opening more or less areas of incubation for small businesses coming up, and try to work out ways on how to give them loans and have access to big facility, which sadly we cannot access this because we're in South Sudan, and neither can you in Tanzania, but yeah, they got a few $1 million from IFC, which is limited in Kenya, so we're not going to get it. But the thing is, there's a bit of progress, there's a bit of, there's a way forward for you. So you actually, now it's up to you to seek the information. And I think that's why you come in with the open fences and all that, and all these platforms, is try to now find out the right people who actually can go that way. And being pioneers, then they'll actually encourage other people to follow up properly as well. And for example, create up softwares like what is happening. And I'm very proud of how Kembu is doing. I was even shocked. We've gone way ahead of what I expected compared to some of us. But of course, which is good, because having a whole system integrated, both the IT and everything else, you have the data coming in. You know what the problems are within the county, and you can go forward now to address the whole country issue. They're very prepared in terms of the whole coordination of the lakeside issue. If you add nutrition into that, you already have a perfect system. And it's just about how do you now integrate all these small developments. And if you have a beautiful open source system that can have all these plugins, you're on the right track. And I think more companies will be joining in, more VCs will be coming in because now they can see the benefit of where your product, for example, your software can fit into the ecosystem. And then they can find a way to monetize it even more. And then you can have a VC coming in, and you can have a bank saying, okay, maybe we can actually throw in some of this. Or a big hospital buying a stake in the software and trying to upgrade it that way. So there's a lot of promise coming from the Kenyan side, and we will learn to adopt a lot of that, inshallah, very soon.
Yeah, so we have had success stories from Kenyans, but I can assure you Tanzanians have very good success stories as well.
Sorry, but let me give you an opportunity to tell us a story.
Actually, by the way, Tanzania has a very, very vibrant young VC community, and it's about time we start looking into them. They'll be shortly new coming out soon with their social development funding models that they have internally, more as private, everything else. And wanaongea Kiswahili.
Okay, so after the past, and you have seen how difficult it is to secure funding, despite how good it is. I mean, your bankable project is. As after association facility in Tanzania, we realized this, and we thought that we should have something where our members can come and get funding without collaterals, without having anything. Now we have like 1 million USD, the quantity USD, and we have we opened an arm called Afia Microfinance. So we have registered it as a bank. Now our members can come and borrow through our Afia Microfinance, and then grow their businesses. So that's the innovation that we took as an organization, private sector organization, so that our members they can borrow 50 million, which is equivalent to how much in dollars? Would be like $5,000 to $10,000. No, to $25,000. Yeah, so for pharmacies, small dispensaries, that is enough to run their facilities without having any hurdles. So, but we're striving now to make sure that big hospitals can also borrow, because you can't just give 25,000 USD to a big hospital. It will do nothing. So now that's what we are trying to innovate and see how we can get big funds. We have been working with farm markets, trying to make sure that we get big funds. They bring money to our Afia Microfinance Bank, so that big hospitals, big farm industries, can borrow without being required to provide big products. So that's that's innovation that we came up as an organization as after. Thank you.
Thank you very much, Dr. Makwabe. And indeed, that's progress in majority of our health facilities here and other health entrepreneurs running other things. They've been able to grow with the support of ISU, with the support of pharmacists, in terms of developing such products where collateral is actually not needed. Indeed, even when you mentioned about equity, I'm part of the Equity Afia franchises, and indeed, the only way to grow an organization is to allow people with ideas to actually implement them without creating bottlenecks such as collaterals, because majority of us within the Equity Afia network, we're young doctors. There's no way we were ever going to be able to provide collateral for anything. So indeed, your facility then becomes a collateral. So that is how we're able to stimulate investments. And maybe before I hand it over to Noel, John Kamara, I've had an opportunity to interact with Afia Records, and we haven't, I was expecting a lot more enthusiasm within the Kenyan setup, even the private sector taking it up. What will be the change? What do you foresee as a change for us to be able to give patients that power? What do we need to do?
I think I think traditional models are still stuck in people's heads. So people, I work for startups in Europe who started things that was not status quo. And 20 years later, one of them called Google when they first started, they're the biggest company in the world, but day one, nobody believed that it would work. So I kind of find myself in the same position. A lot of education is required, non-stop. A lot of trust needs to be built. But also, letting both the health providers know that you can also generate revenue through this new model of thinking. It's actually a better way to generate revenue and keep your customers longer and more alive and healthier. Ultimately, which is what you want to do. And for a state or a country, it's the same thing as well. As you said, the healthier the people, the better the economy. So I think a lot of education, we are still consistently, we realize that we're pioneers. And when you pioneer something, you have to keep educating people. And you find pockets, but we find pockets of, doctors, health practitioners who are now seeing the opportunity that this provides. And I also think the more success we get outside of Kenya is beginning to show that what we're doing actually makes sense. I think 80% of our success has been outside of the country, which is also, I think, also help build the confidence. But it's a challenge to change. It's just a mindset. It's not the fact the product works, it doesn't work. It's just a lot of people. I'm not a doctor. A lot of people in healthcare are stuck in a particular mindset. And I applied when one of the hospitals, I applied a fintech revenue model for them, and they couldn't get their head around it. But it saved them so much money and made them so much more money. But they couldn't just understand that this could work this way. And just to add to last thing, what she said, there's so much money in healthcare. There's a ton of money. If you just rethink the model for a second, as what should you worry about? That's also just the model and education.
All right, thank you so much, John. And I think in the next few years, as we speak, majority of us will raise our hands to say we actually have our personal medical record. So I'll hand it back to Noel, maybe to engage the audience a bit. And and any other questions?
So thank you, everybody. I think we can have a few questions from the audience. You can just put your hand up, and maybe Nelson, you can pass the mic. In the meantime, as we get the questions, anyone have a question? There's some there. Yeah. As it goes towards that, I think we can allow Dr. Ryan to say something.
I think I wanted to just give a public health perspective to the question you've posed to the private sector. And even to us here, we are like being competitive players, trying to spur the change in the sector. Like for example, right now counties are developing our integrated development plans. The integrated development plans are 5-year plans that are going to guide how counties are going to expend money for the next 5 years. This is, for example, if John wants to come into, for example, a county, this is a time when you're supposed to be lobbying and pushing the medical superintendents to put your product as part of their agenda, so that it can come up and be part of the agenda. Because one of the challenges we found is, for example, this will only be the second round of CIDPs being developed since the evolution occurred. The first ones really bound our hands in terms of what we could ask for money, in terms of what we could extract from our current offers. So now we're moving to this model, we're talking about new funding models for also public park innovation. To have these conversations now, and it's a very tight schedule. By the end of this month, the CEC's finance will be holding the CIDP documents. Public participation will happen by August, by September of this year. The whole process will have closed. The next 5 years, you will be start doing whatever you have decided to do now. So I think even for the private sector, as you're looking for these models, it's important for you to develop an understanding of government processes, because the government has processes. Sometimes we call them bureaucracy, but another way to look at them is that there are structures of engagement for a lot of the things we're discussing. Thanks.
I think that is our main insight. The Kenya government protocols and processes cannot be beaten by any private sector in this country. That I began to a long time ago. And so if you want to work, you need to understand how things work before you make things work. And I think that is very critical. So maybe we can go to the question. Somebody has a microphone? Yes, go ahead.
Good evening, everyone. I'm Robert Manya. I work with a company called Robis Limited, a private company. We develop softwares for health sectors. So a few weeks ago, let me say a few months ago, we noticed something different when Corona came. We realized that so many people are having complaints, nice ideas, suggestions, and emergencies. And this one basically questions that we have. So as a way of giving these people power, just the way we have been discussing today, we really appreciate the discussion. We came up with something called Patients Digital Suggestion Box that will want to be implemented in Kenya by all hospitals. This is just a technology and innovation that will want all the patients to be able to give suggestions anonymously to the institutions. They can post suggestions, recommendation, or complaint, because whenever you accept feedback, such kind of institutions do grow. And we have realized some people might be losing more money in this sector because they don't know what the patients want. Therefore, through this kind of technology, which they can use, therefore, they can use some screens like the one that we have, like queue management system. They can just go there and type whichever suggestion they have and really help. So I think with us being open in various institutions that we are in, willing to try new technology that we have in Kenya, then our patients can have power, and we believe we can be able to drive this technology ahead. So I suggest and request every individual that if you are willing to be part of the exhibitors here, we'll be willing to give a trial version to your institution to see how can we use technology made in Kenya, and many people will be learning is because the manual suggestion book that we have been having, nobody reads it. Sometimes also because of handwriting, you are not able to read the correct information. But because of the software, the spelling is the same, the handwriting is the same, to be able to get the information. And you can distribute this to various departments. For example, complaint department, they get what belongs to them. And the innovation department, they get what belongs to them. So we hope and request to work with all of us so that we can push and then maybe give more funding to such kind of technology. Thank you so much, everyone.
Thank you so much. Thank you so much for that. I think Kenya is not short of tech. In fact, I had a flash in my mind. I was like, if all the tech and all the ideas that we had in this room alone were scaled to national level, what shift would that cause in the healthcare system? Great. So let's have another question.
Hello, everyone. Good evening. My name is Maina Gibson. I'm a pharmacist. I've been following the discussion on investments even from earlier. So I just want to gather the opinion of the panelists on something. When it comes to the space of public health, and most of my experience is in the rural areas and the community healthcare. Some of the innovations that you can come up with in solving those access issues are really non-profit. And as you look at it, you see it works. But as we agreed, profit or making profit is a very important when it comes to investment. But some of those solutions in the global health space are really non-profit. So I'd love to know what the panel thinks about some of those solutions. Are they workable? The people up with some of those solutions? What are the options? Thank you.
Can I ask Joe to answer this, because I know you've developed fintech models. So I think maybe you can have a perspective on that.
I think one of the things that you looked at, consumer, I didn't come from a pure health background, so I came from a fintech and a consumer background. So I always look at everything that I do has to have a commercial viability. I'm not an NGO, I'm not a charity, I don't want to be one either. So, but it's impact driven or would appear commercial value because I am building a business as well. So even in rural communities, what I do decentralized pricing. So decentralized pricing means I use a lot of different types of data to design the pricing for specific geolocations of what I do. And as I do that, I will be able to re-aggregate the pricing at another place to actually balance my sheet. So it's a very simple model. It's a mechanics around it, but ultimately what happens is, especially in healthcare, because of the way I've also designed the platform, people move all the time. So, if I give you a very basic model here, you might end up going to 34 places. You're still paying me the money that I want to eventually, but on day one, it's not expensive for you. And then if I come to Nairobi, the model is different. So you use a number of data stats to design your pricing model. Because the pricing model is dynamic. That's also one thing that I realized. I use dynamic pricing models. So I don't do license fees. I don't do maintenance fees. None of those traditional stuff because it's just a headache. Nobody's going to. So again, and obviously the end game is also different because I'm in the business of data. That's my business from a global perspective. So even what I do today, it's a different type of model. But yes, everything that I do has a commercial value to it. Might not happen on day one, but on day 2 and day 3, the commercial value will be clear. And I can talk to you about how we've actually earned revenue from people in the villages without them ever thinking that, well, we're earning revenue of them.
Thank you. I think one of the struggles in healthcare is that for the longest time it's considered a social good. So a lot of us struggle with perceiving profits as a social impact. And I think it's okay. As long as you're giving service, delivering what you need to do to the community, making a difference, I don't think there's anything wrong with making profits. I didn't say exorbitant profits, but it's okay to make money as you make social impact, which is what the private sector does. That's the business of the private sector. Yeah? Maybe someone else on the panel had an opinion on this. Yeah.
One of the things I know is that large organizations, especially in the private sector, are not the best partner when innovating. Rural organizations, the ones in small towns down there, best. About that facility you're talking about in a rural, like let's say we talk, and the like, they tend to be very good for innovation. So because there is no bureaucracy, and with the sub-county team, you're able to even 10, 20 facilities at the same time. And here in Nairobi, when you work with a large organization, they will tie you down in one center. So the value, especially with working with those types of facility, is in growing, stabilizing the innovation, and not the commercial value itself. Again, now when you come with that innovation that is stable, documented, and the kinks have been straightened, when you come to Nairobi, then you're able to go to commercial phase very quickly. Because if you go to any of these top 3 or 5 hospitals, they tie you down for 3 years before they sign your contract. But if you have done all the straightening from those rural facilities and the like, it will cut down to 1 year. And that's where the value is. Seeing the rural place as a place where you can innovate, the county hospitals as a place you can innovate, you may not get a check, but it will cut a lot of wasted time when you work with the ones who have the budget. Thank you.
Any more? Okay, I think maybe we can take the last question. Sorry, 3 more questions. We will take those last 3 and then we can close.
Okay, good evening. Thank you. My name is Otieno. So I work for Systems Evolution. We are a consultancy in the health systems strengthening space. I also serve KHF as the Vice Chair, Health Regulations, Quality and Standards. And my question goes to the beautiful success stories that we've had. And maybe we may have maybe Tanzanian experience also. When you listen to these success stories, there is something that comes to mind. I'm also an entrepreneur, but what comes to mind is, wow, they did it. So what is it that enabled it? My question, very short. What enabled you or enabled the startups? What are these key enablers that these groups sitting here should go back home and start working on as things that can inspire these innovations, so that we don't get into the valley of the valley of death or the traps that there are for entrepreneurs or young businesses coming in. The enablers that we look and share with us. Thank you.
So maybe you can give that to Dr. Tobu.
Thank you very much. How we did it, that's a tough one. I would say, one, a lot of resilience, lots of lack of sleep for a long time. But just being tough, being rugged, and always be innovative, actually. Be ready to innovate, be ready to change. Be quick to adapt to how things are going, because market trends will change, situations will change. So you'll have ups, you'll have the downs. In my case, we had a currency devaluation that happened first. So one day we were sitting in the evening, and on the radio they said the dollar will value this, and from now it will be valued that by a factor of 6. So all of a sudden, all the money in the bank lost value by about 80%. So you have to innovate. Think how you're going to work again, how you're going to start, deal with your clients, deal with this. Then we had to go through a civil strike again and come back and bounce. And you have to figure out now niches in where you can actually make a better profit, for example. So over time, I changed my perspective in how we actually work. Which thing that sits within the medical field we actually work with. And some are very profitable, some are not. So it was more as a trial and error sometimes. Made some losses here, made some profits in some areas. And also be very wary of people copying, or actually you copying other people's sites. It's good to imitate and learn a few things, because in one of the areas that actually ended up being very good in was we had to benchmark ourselves with what was lacking. There was a gap, so a gap, and I had to go to Khartoum to benchmark against a well-known hospital at the facilities they were offering and the systems they're doing, before coming back and trying to replicate it. But actually I was doing it in a totally different country, so it was much easier and could actually develop faster and better. So think out of the box. Actually, there is the box. Just think.
Maybe Sharon can chime in terms of even scaling, when you had the idea, even coming from not a nutrition base and now working in the nutrition space. How have you been able to navigate to now even get the hospitals that you're able to work with?
So firstly, I must say that I'm a very curious person, and when I have a problem, the whole village knows about it. I do not wait for someone to come and help. I go and ask and ask and ask every single person I know. So I must say that this company has grown out of the grace of everyone else. Because firstly, when I thought about the idea, I knew someone who was part of the team that had built eCitizen. And when you're a software developer, you do not understand the work that gets into building technology. Now I understand, because I had to go through Winga so that I can be more sensitive to my software developers. And I did a 3-month course, and I respect them even much more than I did because I'm still not an engineer and I'm not close to being that. But I think the aspect of having to sit down with someone and explain to them that, okay, I'm trying to build this technology that is supposed to personalize nutrition based on a disease. And then I had, the first thing you told me is, Sharon, this is impossible. That's the first thing. It's going to be absolutely impossible, because firstly, you need to have the list of all the nutrients required for this disease. Beyond that, you need to have the quantities. And then because you want to mix it with the food, you also have to have the list of all the nutrients in all the foods that you were speaking about. So that's the first thing you need to do. Beyond that, Sharon, it means that you need a research team, you need everything. You told me, I wrote it down. I got out of there, first thing I did is I I started calling around and asking about who does this kind of work. And firstly, I thought it would be nutritionists, but I found that it's not nutritionists. The right people to do this are actually, sorry, do you hear me? They're actually medical microbiologists because they understand about the physiology of disease and they can bring in the nutrition aspects so they can be able to see exactly how nutrition plays a part. Being able to do that, speaking to people is so important because I might say I was lucky enough to get an angel investor into the company within the first 4 months of actually thinking of the idea. And just being able to do that, get an angel investor in, bring the team, and be ready to learn from everyone else. I would think that's the most important aspect of it. But in terms of scaling, these events, I think these kind of events scaled us completely because the first time we launched at the Nairobi Innovation Week, the one that's normally held at the University of Nairobi. And I remember we were all there, it was quite funny. We were all there with the technology and forcing everyone to get a nutrition assessment. But just for them to be able to go through the process and say, wow, you know, that acknowledgement, wow, is what took us to the next level because at that point we got discovered by, for example, Vilgro East Africa. And beyond that, that's when people in the county also realized this is actually something important. Would you like to come and set up during the Kenya Cardiac week? Because the week where it's all about the hearts, you know? We set up the provided nutrition services at Kenyatta National Hospital during the outreach, got recognized there by someone else. So part of giving is growth. So you just need to know what your balance is and just make sure you're giving, you're not giving and going broke. Because at the end of the day, they would rather pay 20 or 50 shillings than. Thank you.
The other question? Go ahead.
Thank you, everyone. My name is Kefa. I work with MTIMA. First and foremost, I want to recognize and, of course, appreciate the greatness we have, and, of course, also throw in a challenge because part of innovation, you find yourself, of course, getting to either replicate something or improve something that is already there. But my question is, what will it take us? What will it take for us to maybe sit down and come up with something that, of course, is diverse? And by diverse, I mean when we talk about health information management system, which, of course, ever since we came yesterday, I think I've heard of around 4 companies, and you find that the company that came in latest actually did an improvement of what is already there. So, what will it take us to have one system that, of course, is diverse enough to solve the problem that we have? And a good example is when working with the hospitals, you come in as a system and they ask you, we have a lot of fingerprints because we have a lot of systems here. Why don't you guys sit down and come up with one system that we can only have one, for example, one fingerprint that, of course, is able to integrate and use these other HMI systems that we have. Yeah, thank you.
Dr. Masibo, you can go first.
Thank you. I think my question will go to Dr. Makwabe and Irene, probably. There's almost some shame when we discuss profits in the healthcare sector. I think even Dr. Noel has just said we are allowed to make profit, just not exorbitant. There's always some shame to it. And I wonder what's your opinion, especially even in Tanzania, what's happening there? Do you think we need to control prices in health? Do you think we need to regulate profitability? In Kenya, we have the regulator giving what I would say quite reasonable rates that the national insurer is saying is too high. So is there a need, for instance, to consider health as a social science and try to regulate the profitability in health, or should it be a free market?
Well, I think we have 2 questions. Maybe I can ask Dr. Mube to take the question on innovating and looking at things as a whole. And then maybe, yeah, you can take Dr. Masibo's question. So there's one last question. Should I just take the question and then we'll distribute the responses? You can go ahead.
Thank you very much. My question goes to the gentleman on, is it your left or right?
My left.
We have something in common, our hairs colorful.
Sorry, just talk louder into the microphone. I think
We have something in common, our hairs are colorful. Earlier on, you talked about how to get all the information. What laws and regulations do you think need to be put into place? Because, number one, we cannot guarantee, or you cannot guarantee, the confidentiality of the information on somebody's phone. You get what I'm saying? And you know, the issue of information of health is one of the biggest problems. And that is one of the issues that even private insurance companies have been grappling with, you know, because they get the information and they use it for the wrong reasons of denying people further issues or whatever it is. So how is that going to cause it doesn't? And then lastly, how you're the first ones, they are many. How have you, what is it you're doing that the others are not doing, or how are you going to integrate with them?
Okay, so thank you for the questions. I think let's go in that order and then we'll finish with him. And then I have a story, a success story, which I'll give at the end as the last person. So I think let's.
Thank you. Question was whether it's possible to have one single system that can do a lot of things. So it's not possible, but what's possible is for different systems to have the same standard and the same type of terminology, and that's where KHF, where universities, but at least for KHF, the city committee, that's something that we have been trying to figure out, because we don't use different electricities, and when you go to any hospital, you'll find an MTBA reader, a smart reader, as guys slid, readers are there, but the computer is the same. So if we have the same standard and terminology, then the hospital is the one that will be going to the hardware shop and buying the reader that they want, and it should use the same standard for fingerprint, because at the end of the day, even you find ourselves, you guys, as a KMC, but we go to the factory to clear the same data, only that they're labeled differently. So standards and terminologies, that's the work of KHF with the Ministry of Health, with the Ministry of ICT, and that's, I think, the value that we all want from KHF. Thank you.
I think the second question was for Dr. Makwabe. And
all right. Thank you for a very good question. You know, now I realize that what is happening in Tanzania is exactly what is happening in Kenya. So some regulatory bodies trying to regulate issues, including pricing and profitability. In Tanzania, for sure, we have several proposals from the regulators, and we rejected that proposal. Because if you allow that, you know, then there won't be any sustainability. There is nothing called exorbitant profitability. There's nothing called exorbitant profitability. Because at the end of the day, people will choose where to go depending on what they have on their pockets. No one will be forced to go to somewhere where he can pay much while he knows he can't afford. So I can give you an example. In Tanzania, NHIF, they brought a price list where most of the price were significantly reduced, including procedures, medicines, lab tests. Then we had to sit down with them and with the government as a regulator and discuss, say, look, this is the exact, this is the real price. This is this is how it costs. The actual cost for this procedure is this, but you're still paying this. And then that was 1.5 years ago. They all went through. It isn't the shelves. You can't accept that. So the private sector
you have to, after, for example, you have the moral responsibility of making sure that the prices that you are charging, they are enough to make us sustainable. We can treat our patients until being sustainable. Because if we don't do that, our centers, our hospitals are going to die. And if we die, the whole chain, the pharma factories will also die. The pharmacists will also die. So that's why we collaborated with Tanzania pharmaceutical industries together to discuss about this, and that proposal was shelved. So I think that's what we should do in Kenya as well. Not allow that. So cutting prices is not something that is sustainable, and we should not be entertained.
Hello. It's interesting you came from an insurance point of view, saying that the insurance, of course, is saying the prices are too high. Of course, insurance will say that because they know very well the last thing the insurance wants to do is pay it. They don't know what a car accident or anything else. Try explaining to an insurer to fix this bump or whatever it is, and they will come up with issues with reasons why it should not cost because they have a cheaper garage where you can take your car to get it fixed. Anyway, back to point. As someone who imports medicines and also runs a pharmaceutical chain or retail, yes, I understand there's a point whereby you cannot go above in terms of you have to make an ethical profit. Okay? You have to make an ethical profit. And I would say I've been in situations whereby I've had to buy medicines that I have imported from a different pharmacy very far away because I could not get access to the office at a price almost 3 times what I was selling, and I was almost crying. But I had to do it because at that time there was no other place that I could get the same medicine there. Yes, very many what you do put some people do excess profits. Some people do actually put normal profits, which allow them to be sustainable, to maintain the employment and run the business. Because after all, let's look at it this way: private health is a business and it has to be sustainable. So I don't know what the insurance uses as a benchmark to say it is too low. Maybe you could actually try to see about raising a bar or lowering a bar, because you cannot have, or you should actually have a range of pricing instead of having a benchmark, a fixed price. You should have a range of pricing. Say minimum is this and maximum should be this for a certain procedure, for this, for this, for this. Having fixed price actually kills out everything else, and it will mess up your business in the future. Thank you.
Thank you. I think I'd respond to you from an accountability space, but also partner space as well. An ideal situation in a healthcare ecosystem would be a place where a patient is empowered enough to be able to make choices, informed choices, where to seek services, having known about the quality, the availability of services, and we talk about quality. We also have aspects like the timeliness, how patient centered is this facility, and also issues of equity, how equitable the services or anything like what to access from a facility is. So when you talk about the pricing of services at facilities or just the whole healthcare service, it would be a perfect ideal situation for a patient. We wish the healthcare dynamics would be in such a way that it would support me going into a portal and just knowing I'm having the symptoms, I might be able to pay from a certain price range to another. But then that's where the researcher comes in. We wish to see much, maybe be able to test out and see if that works. But as you said, having a fixed price rate would be tricky, but a fixed price would be tricky, but a price rate would be. And from the patient's perspective, I think it would be nice for them to be able to make informed choices for the services they seek. That if I'm going to go to a public facility, then this might be the price range, far away from what we see on service charters. And if I'm going to seek care in a private hospital, this might be the price range. So that would be an ideal situation, but I think further research and just understanding on the health dynamics and how all these factors in would be essential. So that's a potential research point. Thank you.
I think the final question was to James. If you want to take this question.
Thank you very much, sir. On your second question first, why we are different is because we don't build software. What we're building is a human-centric platform that is focused on the only moving part in healthcare, the human being. That's the one person that consistently moves. And for you to build anything around that person, you must understand the level of complexity to build data structure around the human being who moves. So in that place, security, compliance, and governance of that data are extremely important part of what we do. I can authentically say we're the only platform in Africa in healthcare that is now built on the blockchain. It costs a lot of money. Regular digitalization of platforms, people can hack into them. Even your database or whatever, people can hack into the service. But we've just built on the blockchain and it costs us a shit ton of money. Just first to build the security layer, just to protect. Now, the way to look at it is gold. They say data is the new gold. Why is gold very expensive? Because the cost of mining gold from the ground first, then the cost of cleaning it, then the cost of repositioning it, then the cost that you actually, so all that cost, that's why gold is so expensive, is data is that expensive to actually create a single source of data that is protected enough. So when we build this thing on the blockchain, which is demonstrated consensus health, it basically shows you that first, what that means, the record is immutable, which means we ourselves are protected. We're just lobbying FIA right now to be the only black company on FIA compliance globally. Okay, so we are spending a lot of money purely on security, privacy of that data. The second thing is, every time you do databases, the one important thing you must realize about the blockchain is important is timestamping. So you can timestamp every single source of information that goes into that database, which means when somebody runs an audit trail, they will know that yes, this person, because that data cannot never be changed. Once it's stored, you can't go back and change it. You can add on top of it, but the original format will always remain the same. This is the value of the blockchain. This is why we've gone down to this route. And I represent this to the US State Department, show them what we're doing that is even way higher than pure compliance. And then on the other side, people analyze data is the most relevant structure of how to store data right now to protect you. We've gone one step lower to what's called descriptive data. So you redescribe the database and you create a pod. And when you redescribe, this is our own technology that we're coming up ourselves. So these are our own proprietary technology that we're building, which we are showing to the world, not just Kenya, but in places where compliance is extremely important. So for us to be able to be live in the US market, you must understand the amount of work we're doing around. So when I started my statement saying we're a deep tech healthcare company, we're spending millions of dollars just on security alone. So when we take that, then we look at the privacy of that person. When we store your data, for us, the most important thing around that is privacy. And privacy also comes back to, are we using your data for something else? That is really what is authentication of that privacy and making sure nobody else can hack into that privacy and also making sure that we don't use your data for anything. So we protect ourselves. So anybody can come audit our trail to then see what we do with it. So, I spent more time to show you the layers of technology and why investors are pouring money at us is not because of actually acquiring customers, it's just the technology level that we're building, which we are going to sell to the rest of the world. So we're building our own infrastructure on day one. And it's a whole different set of thinking when you know how to build databases around a moving entity. And that's why the blockchain is a very important part of what we do, but also it's extremely expensive. That's what nobody is doing.
Thank you. So I think maybe I can give my story and then Elizabeth can close. So I am a co-founder at the Pathology Network. So I'm a consultant pathologist. Maybe I need to demystify who a pathologist is, because I think in the Kenyan setup, at least, a pathologist is always perceived to be the person who only deals with forensics in terms of doing postmortems, which is not actually true. So we actually specialize in laboratory medicine, and for those of you who are in the private sector, a lot of the lab tests that you do are actually signed out by the pathologist, and we connect the tests that you do to the primary doctor for decision making and patient management. So we realized in Kenya we're about 160 pathologists. I'm also the chair of the Association of Clinical Pathologists in the country. And we realized that pathologists, number one, because we're highly specialized, we're also expensive. And so we're not accessible to most facilities where we're needed. And because we're very few, most of us are in the urban centers, and thus we're not able to serve the rural centers. So my colleague and I were thinking, and we're like, so how do we move all these labs and work that needs to be interpreted by pathologists for best patient management? Because, currently everything is patient-centered, and that's what we wanted to achieve. And so we started a company, a software company, that then moves all this work to the pathologist, has it interpreted through our software platform, and we send back the information to hospital. And so charge fee for service, so the facility doesn't need to employ a pathologist, but they get pathologist quality reports. And that's what we do. So we're currently in facilitating 30 hospitals of FBO, private sector. We work with Marbit County to do all their work, and we're able to give them service. And because we're a software platform, we are able to go global. We do digital pathology, we're able to send the samples digitally to actually provide service. And for us, at the end of the day, we wanted social impact. And I think we're able to do that. So a lot of patients are removing probably tumors. The surgeon does a great surgery and removes tumor. But what happened, it would stop at that, because then it wasn't being interpreted. So there was no information for the oncologist to then begin chemo or radio brachytherapy and so on and so forth. And I think it's been a great success because, for example, Marcy County now gets results. So then they're able to give the oncologist a proper report by a qualified pathologist. We also do quality management systems, so we check on the quality of the report. And now there's continuity of care for the patient, and there's hope. So I think that's the story I wanted to give, because we're talking about stories. And maybe for me to close, I think Dr. Lea is gone now. For me to close, I think healthcare is a success story. I think, we look at the doom and gloom, but we don't realize we're actually making a difference at whatever level. Even for those who are not healthcare workers, you are impacting the population. And at the end of the day, we have a healthy population, we have a healthy economy, and we can grow as a country. So thank you very much for sitting with us through. I think it's raining. For those of us who are religious, God is blessing us. It's an inconvenience, but then we have food. So thank you.
No, indeed, you can walk down, and thank you to our panelists. Give them a round of applause. Yeah, we thank God for the rain, because you're stuck here with me. Thank you.
So thank you so much. It's been insightful. I left the story flow because they are beautiful stories, like you said. So at this particular time, we're going the session. I'd like to remind you as well the online platform that we used, it's still open, it's still active as well. And all the sessions that we've done for the past 2 days are live as well. You can log into them. It's https expo.flow.bz. So this, as we were discussing details on innovation, at this particular time I'd like to welcome a group of students